Good afternoon and welcome. We have here with us Mr. Steve Posnack, Principal Deputy Assistant Secretary of Health Policy at the Health and Human Services in Washington, D.C. Steve, thank you for joining us. We appreciate your taking the time to be with us. People over here have a lot of questions, just to give you a heads up, about policies in Washington, D.C., about what we can expect and anticipate. There's a lot of energy and excitement over here in the conference. I wish you were here in person. Of course, the focus has been what will AI do in terms of opening opportunities for innovation and transformation. We have leaders from business, we have leaders from provider community, payers, we have researchers and scientists, medtech innovators, startup guys, venture capitalists, and we are all saying the opportunity is now before us as a nation to redefine how we think, redesign, and reposition ourselves for the future to deliver better care for our systems and better health and well-being for our people. Having said that, we would love to hear from you as to what you're seeing as the emergence of policy structures at HHS. You have been at the forefront of policymaking process for years, and we're really excited to have you join us today. So please take it from here, and the format will be, once you're done with your remarks, we will turn the floor over, open it for questions, and we look forward to your insights.
All right. Thank you so much. Appreciate the warm introduction, and wonderful to be with all of you. I'm going to pull up my screen share, and while I do that, I want to give a initial shout out to the tech support team. We had as usual with health technology, a Zoom crossover platform issue between the government Zoom and the commercial Zoom that you've got for the conference here. But we made it work, and we got it on time. And the other thing I can say to you, since I'm on the East Coast, is greetings from the future. And while we're talking about the future today, I'm going to give you a bit of a whirlwind tour about what's going on in healthcare and digital health across the federal space, especially within HHS. And then, as Gopal mentioned in his intro remarks, an opportunity to field a few questions from you all as well. So I will just dive right in. First, I wanted to give you a quick sense about our office if you are unfamiliar with the work that we do. We are, as was indicated in my title there, we serve in a dual-hatted role as the Assistant Secretary for Technology Policy and Office of the National Coordinator for Health IT. We were implemented in executive order in early 2004 as part of President Bush, then codified in law in the HITECH Act of 2009, and received additional authorities that you may be familiar with if you've heard of information blocking or the 21st Century Cures Act's FHIR API, standards-based API requirements. Those were part of the 2016 law overall. So we really operate at the intersection of clinical informatics, the data standards that are needed for interoperability, be it from electronic health record systems, from other types of patient portals, from laboratory information systems, you name it, in terms of the broad ecosystem that exists out there from a health IT and digital health perspective. We're always looking at new ways that we can help collaborate with industry to standardize some of that data. And then, as equally mentioned, there is probably not a day that goes by, especially within the Washington, D.C. area, that we're not talking about the health policy implications, be it for drug or device approval, in terms of our colleagues at FDA, and that intersection with the work that we do, with our colleagues at the Centers for Medicare and Medicaid Services, in terms of payment policy and other types of quality programs. We've got a number of other collaborative efforts, and I'll get into a bit of those going forward in the future. But when you think about our office and the work that we do, you can kind of keep this in mind, that we really are kind of traversing all three of these domains any given day, and really the intersection of those, which is, I would say, the sweet spot in which our office works. Okay. So just giving you a sense of the kind of four core areas of activity that we have, you may be well familiar with our certification program that is longstanding from that HITECH Act that I mentioned at the earlier slide. We have been in the business, so to speak, of certifying health IT, in particular electronic health records, for their support and usage in CMS-related payment programs and incentive programs. So many of you may be familiar with what was called meaningful use a decade ago, and now called promoting interoperability through our colleagues at CMS and their programs for payment and quality. We still run the certification program that regulates the electronic health record developers, in the for the most part, in terms of their functionality in some cases, transparency requirements, reporting requirements, and more near and dear to our heart, the data and interoperability requirements that they need to meet from a standards perspective. And so, as we've got that kind of digital infrastructure, and I didn't include our EHR adoption slide, as part of this presentation today, but just to, go through over the better part of the past 15 years, we've seen rapid adoption early on, and now, to a certain degree, a plateauing effect, especially with hospitals. We're kind of near 98, 99% of hospitals have gone digital. On the ambulatory office-based physician side, we're, inching our way upwards above 80% of office-based physicians having adopted electronic health records. And so when you have that digital footprint now, you can start to do things that used to be 10, 15, 20 years ago, imagine ifs. And so one of them is about connecting all of the different data sources together in an interoperable, networked way. And so as part of the 21st Century Cures Act in 2016, Congress charged us with the responsibility of implementing what's called the Trusted Exchange Framework and Common Agreement. In acronym speak, we say that as TEFCA. And so that went live in December 2023, and we've been working to expand participation in TEFCA. Certainly with a new administration, coming on board, there's work to be done to brief officials. I was going to try to get my boss to come, who's new as of, I think he's 6 days old now, having started last week. But his boss just started yesterday, who is our deputy secretary for the Department of Health and Human Services. And so he got called away. Otherwise, Gopal and I were trying to get him to make a cameo appearance at the beginning here. But you're stuck with me for the kind of presentation today. So, we're advancing a lot of the initiatives that came out of the 21st Century Cures Act. That first 4 years of implementation happened under President Trump's first term, spanned across the Biden administration, and now, obviously we're back into President Trump's second term. And so there's a lot of bipartisan support when it comes to digital health information technology, and interoperability related work. The other thing that's really spanned across administrations now is our work on health data standards. The United States Core Data for Interoperability, otherwise referred to as USCDI, is really one of the crown jewels of the work that we help to coordinate and lead across the Department of Health and Human Services. And so I'll talk a little bit about that in just the next slide. And then lastly, industry coordination, where we have the opportunity to connect with, participate in various consortia, help lead public-private collaborations, and make investments in different areas. That's also work that we try to do to get out there in the field and to engage with you all. Obviously, give presentations like this, but equally really roll up our sleeves and get our hands dirty in working through particular challenging issues. This is the kind of current live version of USCDI version 5. Maybe depending on the screen size, it might look a little bit like an eye chart. But suffice it to say, it's really grown over the past 5 versions up to the point now that we're at. This is not regulated, so it's really just up there for voluntary industry use. But just wanted to give you a sense of, as we work with industry as part of that standards development, as part of that industry collaboration, we're engaging with our colleagues at the standards development organization called Health Level 7, HL7, in terms of representing these data elements into what's called the US Fire Core implementation guide. And so that's going to be available in the future for those FHIR-based APIs, for patient access, for you all that are out there as clinicians, using apps that are developed. And so as we talk about artificial intelligence, I know there's always that debate between, do we need standardized data? Can we just take all the text blobs and make sense of it? Probably somewhere in between. But having this baseline set of data that you can expect to get from a connectivity perspective via those FHIR APIs is important in terms of setting a baseline and setting some industry expectations going forward. The other thing that we do, now that you kind of have a sense of what the USCDI itself is, if you look at this image to the left, it's almost like rings of a tree. As we expand that core data for the USCDI prime, as I like to call it, in that center, we also are looking to expand specific data needs with our federal partners. So with it, be it SAMHSA or CDC or CMS, or collaboration with the NCI, National Cancer Institute, we're looking and saying, all right, the data elements that I just showed you on the screen before are helpful, but not sufficient in all cases to achieve certain use cases. And so if we look at USCDI plus cancer, we're working with our colleagues at NCI on what are those specific cancer data elements that if we standardized across those use cases, across that domain, that NCI could point to, that could help harmonize some of the requirements that they include in their programs, and that as they work with cancer-focused stakeholders, they'll be able to use consistent data elements for research, for other types of policy and program purposes. So that's a number of kind of activities in which we're involved from a standards and interoperability perspective. Now on to today's topic du jour, artificial intelligence. I wanted to show this as a quick anecdote. We are in a very interesting world where we're getting prompts, and this is a text between my wife and I. I thought this was super cool, as I took a screenshot as soon as I got it. Siri was interested. Hopefully, I didn't trigger my phone here. Interested my agentic software there on my phone. It kind of sorted through my text, and it gave this prompt. And you could probably already tell at this point. For us normally, even though you probably could watch your takeout, I'm not sure that would be as exciting as watching the movie and eating the takeout. And so I was like, kind of just made it just close to where we needed to go. But it's also a good reminder of, super smart systems in place, running in the background, lots of potential, but still making mistakes that, normal people wouldn't make if you had just interpreted that text message. So to ground you in, where we are, I was going to start from the start, which is, in President Trump's first term, he issued certain executive orders, and then followed by President Biden. President Biden issued an executive order as well. That's been since rescinded, but that resulted in two what are called Office of Management and Budget memos. And so the first one, which is referenced as 24-10, is around federal agency use of AI and a variety of different factors that we had to consider from a federal agency perspective. 24-18 had to do with federal agency acquisitions and procurements associated with AI-oriented technology. And so I bring that up just to kind of give you a context when, as everyone's excited about AI in industry, we too, as federal employees and agency leaders, are equally as excited about AI in terms of how it can change and evolve the way in which we deliver services or perform certain functions inside the government to make them run better, to make them run smarter, to make them run more effective and efficiently. And so as we fast forward to President Trump's second term here, other executive order was issued. That then kind of created the cascading replacement of the two OMB memos that I just mentioned, 2521 and 2522, which are now the active kind of guidance to federal agencies related to both AI usage in federal agencies as well as for acquisition related purposes. And they have a different kind of slant on them when it comes to this administration's take and perspective on AI. I did, as part of preparing for the presentation, found this other executive order, which I hadn't necessarily been paying that much attention to, given that it's more focused on kind of education. But I thought, for those of you that are in kind of the education space, you may be interested in looking up that executive order as well. So this kind of represents the broad policy landscape that we're working with. I could give probably another 10 or 15 minute presentation on what's going on Capitol Hill. It's certainly an area related to artificial intelligence that a lot of folks are invested in. Hearings, engagements with Hill staff, and this is an area where not only in the executive branch but also in the legislative branch that they're trying to figure out what's the appropriate role for Congress to play. Are there laws that need to be put in place to help guide agencies or for the industry writ large? Some of you may be involved in some of that, and that can take a few different pathways. In some cases, like you may have seen reported in the most recent news, it could be a dynamic between state and federal related policy setting. In other cases, it could be, for those of you that deal with medical devices or drug approval, that the authorities that certain agencies have, like our colleagues at FDA, Congress may determine that they want to take a different approach that is, that recognizes the software dynamics, especially with generative AI, and now as we start to move toward more prevalent agentic AI, that there may need to be different tools in the agency toolbox to provide the right level of early on guidance, safety and oversight, and other types of procedures and policies that could be put in place. All right. So, I kind of took this from a GAO report. I just thought it would be easy to kind of set the floor or the stage. There are a variety of different ways that you can divide and kind of split the hairs around how AI is being used. But in healthcare, you could divide the world into really two different camps. You have those that are kind of clinical facing, which again covers a whole wide umbrella. And then you have those that are administrative applications that are dealing with making, let's say the back office tasks more effective and more efficient from a healthcare perspective. The things those are certainly interesting and important, and hopefully they will help lower healthcare costs. But the thing that is more interesting to us, and I think poses additional factors and risk, characterizations, are going to be in that whole clinical application space. And these are just a few examples that were pulled out as part of this image. I have another slide coming up, which I'm going to talk through how we think about these things from a health policy making perspective, factors that you may want to consider, things that you may have confronted, and would certainly be interested in your questions as we get through to the end as well. One thing that I did want to highlight, we do have a cooperative agreement through what we call the Leading Edge Acceleration Projects in Health IT, so LEAP in Health IT. Last year, we put out a special emphasis notice recognizing that there's a lot of momentum, a lot of industry related to the use of AI in healthcare. And the winning awardee is focused on nursing-related data and using AI. And so if you want to check out this project, it's available at healthit.gov. The work is a 2-year cycle, and we estimate that the work will be completed and be able to be shareable by fall of next year, so in 2026. So when it comes to AI and federal agency involvement, there are a lot of different facets to the way in which we approach this. And I expanded this a bit beyond the HHS to a broader, executive branch, flow. So again, from our perspective, in terms of health IT used in clinical settings, our office's work, has the certification program, and I'll talk a little bit in more detail in just a bit. The one thing I did want to call to your attention as well is that from a federal agency perspective, one of the requirements out of the Trump executive orders has been that each federal agency needs to publish a use case inventory. And so if you're interested in HHS AI-related use cases, so these are things that the government is investing in and AI tools and technologies that we're deploying, we have an AI use case inventory, which I think has over 200 use cases now that are spelled out across all the acronym soup of the different agencies at HHS. And that is also true of other federal agencies as well. So if you're interested in stuff that the Department of Veteran Affairs is doing, or the Department of Defense, or other types of federal agencies that you may have some intersection with, if they're in making progress and investing in AI use cases, it's likely that they have a website devoted to meeting the requirements of the executive order and subsequent OMB memoranda that were put out. For those of you that work in the kind of legal compliance space, with bias and discrimination concerns associated with AI, that also poses civil rights and discrimination related dynamics. Our Office for Civil Rights, that may be better known for its HIPAA related activities, also has a large portfolio on the other side, and its namesake as well in the Office of Civil Rights, around how these new technologies are affecting individuals. I already touched on FDA a little bit, but probably the most recent announcement as of last week is their own use of AI tools and I included a link here, and I'm happy to share my slides with the team after the presentation too. But FDA is not only in the position of looking and using AI for its own purposes to expedite its work, but also in the position of approving medical devices, especially software as medical device that may include AI now. I believe they have a number in the hundreds that have been approved on the predictive, kind of deterministic side of using AI. They have drug-related dynamics, biologics, you name it. FDA, I'm sure, is seeing it when it comes to an AI perspective. Beyond HHS, I wanted to call out the Federal Trade Commission. Many of you may be aware of the Federal Trade Commission for other, data practices, but generally they approach the industry in terms of, anti-competitive practices, but also this genre that we call unfair and deceptive trade practices. And so, the best example being if a software application or an app said that they weren't going to sell your data and they wound up selling it, that may be something that was not previously disclosed to you, and so the FTC may step in, in those types of circumstances. Back into HHS, Centers for Medicare and Medicaid Services, again, huge agency, a lot of different components within CMS. You've got the Innovation Center, you've got the Center for Medicare, you've got the Medicaid, component of CMS. You've got a whole, it's called CCSQ. It focuses on quality. And so you've got all of these different centers across CMS that will either be in a policy setting role, a guidance setting role, or in various different instances, potentially using AI, again, inside the house from a federal agency perspective as they look for fraud, waste, and abuse. They're going, CMS has already deployed certain tools to help sift through the, millions of claims that it receives each year. As we step into the National Institutes of Health, in terms of how AI is applied in research contexts, the one thing that I wanted to call to your all's attention is that they have a request for information out right now, and I think it runs through July, mid-July, to give them feedback about how NIH can approach AI. And so you can check out the request for information at that link. Our colleagues at the Centers for Disease Control and Prevention are also using, again, AI internally for their workflows and processes, disease surveillance, et cetera. But they also make a lot of investments with states. And so you can see how different funding related instruments and ways in which the CDC funds states and public health jurisdictions can help toward modernization and the use of these different technologies. And then lastly, I'm sure not news to any of you in this space, our colleagues over at NIST, they've published the AI risk management framework that's gotten a lot of mileage. I think that's, a great example where, the kind of neutral standard setting aspect of NIST's role can help give the industry a foundation and something on which to build that spans across different genres and market segments of the U.S. economy. So when it comes to the work that we focus on at my office in particular, and this is largely represented through the ONC Health IT certification program, is that we've come up with an acronym that we call FAVES. I know there are a variety of other acronyms out there that describe these types of AI principles, but we landed on, keeping it, I would say, relatively simple and not too long, but focusing really on the fairness, the appropriateness, validity, effectiveness, and the safety associated with the kind of AI algorithms that we would be looking at and considering for policymaking purposes, and how we describe the kind of high quality ness of the AI algorithms as they're introduced in the healthcare setting. And so we think that if the various stakeholders that may be making these available to clinicians are able to address these principles and points, that will help advance a lot of their understanding and our ability to do analyses and comparability and evaluating for all different types of risk mitigating concerns as well. So as a segue, we responded to the kind of policy dynamic and feedback that we were hearing from the field, in that we knew a lot of electronic health record developers were approaching AI, building these things into their products, different types of algorithms and methods. And we looked at that category and said, the one thing that we can do from a federal government perspective is to introduce more transparency. And so we require, similar to a model card, if you're familiar with that terminology, that electronic health record developers or health IT developers that go through our certification program, if they supply what we refer to as predictive decision support interventions, if they supply those PDSIs, is our acronym, they have to make available to their customers, to those clinician users, information in these 9 categories, which we call source attributes. And so it totals up to about 31. So you can kind of consider them the nutrition facts associated with each of the AI algorithms or models that may be embedded into the system for use. And our hope is that that will equip clinical users or councils or other types of governing bodies in those healthcare institutions to make more informed decisions, local deployment decisions that may differ across the nation, but they'll have that information at their fingertips to be able to have an educated conversation about whether or not implementing something or the scope at which something is implemented is appropriate. So if we take a step back, I like to use some of these graphics too to emphasize a little bit of the humility that we need to have when we approach things. You know, when we get answers from Claude, from Gemini, from ChatGPT, what we get is Tuxedo Tom, as you can see here, there on the slide. But we really don't know what the training data looks like all the time. And you know, I know the area that's caught a lot of people's attention has been on imaging and assessments for X-rays and other radiological evaluations and pathology, and being able to do a lot of that pattern recognition, which I'd say blows people's minds, right? If you can detect a tumor earlier and earlier and earlier because of this AI, that's going to change people's lives, make healthcare better, preventative care better, and it's all great. And so the questions that start to come up become, as we understand the human-computer interaction, as we've experienced in other types of technological, say revolutions or changes, how much do we intend to rely on AI to do things? Are we going to, defer or outsource 80%, 99% of some of the decision-making that happens in healthcare today? And that really is a segue to, how much faith are we going to put into these tools? You've often heard of human in the loop or person in the loop. There are various factors and risk mitigating techniques that are involved in, figuring out the right placement, the right part of the workflow, and how we can use AI as a complementary additive or multiplier to the work that our clinicians, users especially, are doing. The other things, getting down to the bottom of the slide, are public policy factors that we have to keep in mind about accountability and liability. These are things that come up when I'm having these conversations with stakeholders that come through DC, is that, we've had to indemnify, this company relative to the performance of their tool, or this regulatory paradigm makes us accountable, but we don't know how well the algorithm works, and we don't have any opportunity or ability to fine tune it or change it once it's delivered as part of our product. And so you have all these kind of asymmetries that we need to work out, and some of them may fall on Congress's shoulders to determine from a legal and statutory perspective. Some of them may require, us in the executive branch to change the way in which we approach, regulatory paradigms. And then others are going to have to work out, as they usually do to a certain degree in healthcare, through various types of, legal challenges and court cases and other types of precedent-setting dynamics that happen. The interesting thing, for us is, when standards of care change, and I think we're starting to see, this paradigm shift where AI is going to be embedded into particular workflows, or, a sidecar alongside the clinician users, and the day may come when you expect them to get a second opinion, from some type of AI agent, because it is providing some type of, Uber diagnostic, review. And so, we have to think about these things from a public policy perspective as we move forward. At the speed that we want to move forward from, an ingenuity, American competitiveness perspective, we also have to keep these kind of legal parameters and policy parameters in mind. All right, so you may say, we should just regulate everything. but I would probably be the first to know like that's not going to be the right approach. And from experience, especially in the health IT setting, when the rate of change is really high in a technology area like it is with AI, we need to figure out what works best for government. So as you heard me discuss previously, we've taken an approach through my office to just focus on transparency. We don't judge the algorithm. We don't assess its performance. We're not doing additional surveillance on the ones that get rolled out into the field. Now, you may disagree with that policy position at this stage. You may want more oversight, less oversight, more transparency, less transparency. All of those are different factors that we can kind of change. But we have to kind of keep these various different considerations in mind that as we approach AI, the conversations that I get into are, is this about patient care? Is this about revenue optimization? Is it about research? And our risk tolerances for these different use cases and the different domains in which AI could be applied are likely going to be different. And so, those are important factors to kind of keep in mind as well. Again, not necessarily to do with anything from a regulatory perspective, but as we start to discuss policy, those are important differences to distinguish. So the way I think about this and communicate it to everyone is you're going to have this spectrum from end to end where we could do nothing, or we could go all the way to the other side and say this AI is so scary. I know folks like to bring up the Terminator movies and Skynet, that we need to prohibit certain types of uses of AI, and that's certainly a public policy debate. And that type of prohibition would likely have to come from our colleagues over in the legislative branch to pass a law to say, like this type of AI use, for XYZ use case is illegal, and that would just be kind of the colloquial way to describe things. So where things largely fall, and where I've seen work happen from time to time, is that you've got the industry-led side to the left. That includes self-testing, codes of conduct, other types of pledges, all the way off to that kind of threshold there where you have third-party testing and accreditation, where the industry kind of set a standard or baseline or norms for itself that serve as a way for it to self-regulate, for lack of better words, and that's sufficient to kind of keep things moving forward and to provide certain risk mitigations. As you start to move into the statutory or regulatory paradigm, you've got the transparency type policy approach, which I started with through our office. You've got a little bit on the bottom for those that are familiar with FDA, where you can do post-market surveillance. Pre-market, meaning you've got to go through this process and meet these requirements even to get onto the market and be able to sell your product. That would be an example of kind of a pre-market clearance. That certainly creates the most you could say lead up or investment and potential regulatory burden for companies. And those are various factors that we all have to keep in mind in terms of what we're trying to gain out of imposing that level of oversight versus how quickly we are looking for the industry to move and innovate and new companies to come in and provide market competition and the like. So to end, hopefully, with a bit of a positive note, I saw this article a couple years ago now at this point, and I was really inspired by the way in which I wanted to apply it to healthcare. And so before AlphaGo and the computers kicking our butts at this game, which is much more complicated, we knew we were getting pretty handled by computer chess. And that took a little while, for that to ramp up. But again, we were getting beaten left and right by the algorithms from a chess perspective. And then as different companies sought to prove the prowess of AI from a Go, the board game perspective, the takeaway, which are some of the bolded statements here from the article, is that the way in which the players, so think of ourselves in healthcare as policymakers, as clinicians, as data analysts, the way in which the AI approached playing the game was, in some cases, heresy. And changed the gameplay in a way that just had never been taught and had never been expected. And I took from this article that we need to anticipate and expect our understanding of what great care is, or what the best regimen is for treating someone with cancer, is going to be turned on its side, because these dispassionate algorithms and other types of models and connected agents in the future are just going to approach solving problems in an entirely different way that we're just not wired to think about. And my hope is that we will embrace that type of learning and not run away from it, but run toward doing things differently. And as you can see at the bottom, after losing so many times, the strategies that these Go players took as they were approaching the game changed, and it made them better, right? And it made them increase the way in which they were competing. And so I think we have a lot to learn. There's certainly issues that we have to deal with from a public policy perspective, and the whole kind of spectrum at large that I covered earlier. But very much appreciate the time to spend with you today and the invite. Hope to make it in 3D next time. But with that, I will end my prepared remarks here to make sure we've got a few minutes for questions.
Thank you, Steve. Appreciate this very much. Thank you. Steve, while we are collecting questions from the audience here, I would like to ask you a couple of quick things. One, your focus from policy perspective is right now, it appears HHS-centric, the department-centric. Is there anything you can inform us about policy-making process in the White House or in the legislative branch of government, in Senate and House?
Yeah, so there are a few. Maybe I'll start with the legislative side, because that's a little bit easier. There are definitely a few bills in the last Congress. Obviously, a new Congress started as of January. They've been focused on other priorities, I guess I would say, at this stage largely. But there are still a few different bills cooking, some around algorithm validation, different oversight approaches, and I would encourage folks that like to pay attention to that type of stuff to keep your eye on AI-related legislation over the next 2 years in this Congress. On the executive branch side, as you mentioned, definitely focused on the HHS personal areas of interest for the department. There are likely more opportunities for engagement with the White House, focused on competition, innovation, and areas for new players to step up in the market. I think we're still, as much as we've seen the administration move very quickly in certain areas, this is a place where we're looking to get stakeholder feedback as well. And so, for those of you that do have opportunities to engage in the various public comment processes, beside it being civic duty and a good thing to do, it's definitely helping to shape the overall approach that the executive branch is taking.
Any questions here? Let me check from the audience. We have one over here. Yes.
Thanks, Steve. I'm Ikram Khan from Health AI Institute. Great to hear your talk. And we are sitting here at University of Minnesota's beautiful campus, and we are looking forward to federal government to see what are the policies and what are the new investment opportunities coming up specific to health AI from the federal government, both for university as well as for the health system.
Yeah. So in terms of different opportunities, I would definitely keep your eye. We're not a big grant-making agency myself, for ourselves at ASTP ONC, but I think the other larger agencies across HHS definitely keep an eye out for that. The budget process is still being worked out for this fiscal year and for next fiscal year, but I think you'll start to see areas that are aligned with the secretary, deputy secretary's interest. And then some of the other programs that are part of HHS writ large. I don't have any one in particular that I could highlight for you right now that I know that's out the door and open for folks to apply to.
Any developments in the area of grant funding for science and research relative to AI applications within healthcare space?
Yeah, I mean, that again, I think looking at the National Science Foundation, some of the other HHS components as well, probably NIH, AHRQ, as you may know, and trying to think of what other agency might be the one. Those would probably be the top. CDC may as well in terms of state collaboration too.
Thank you so much for giving some guidance. Coming to you sitting at federal level, so a lot of is happening at the international level, and recently President Trump was there in Middle East. A lot of work is happening on the AI space in that region, as well as in China, India, and many other parts of the world. So how you see what's their intergovernment engagement and at international level, especially influencing policy in healthcare, especially with the data transfer and other things?
Yeah, I really appreciate you asking. So my office in particular is involved in something called the Global Digital Health Partnership. I like to describe it as the government geek squad. And so, it's the equivalent to people in roles like mine that are digital health leaders in their ministries of health internationally. So we have an opportunity to informally compare notes, as different regulators in space, or to look, share each other's strategies and have discussions about, how things are looking. When it comes to other international, say fora, you've got the G7 and the G20 where those discussions also occur. Interestingly enough, the various different federal agencies get involved in, I would say, like funneling up information to the various negotiators or teams that work across the G7 and G20. We also participate in various like OECD related activities as well. To your question, there's no shortage of international interest in AI. There is obviously, I would say, different philosophical approaches to how we view regulatory related dynamics and market competition dynamics compared to how Europe does it, compared to how Asia does it. And so, those are things that will get worked out, I would say, over time. But that's to some degree led at the White House level in certain of these interactions.
Any other questions in the back over there? Steve, a couple of follow-up questions over here. Are there any opportunities for us here at the University of Minnesota? We have a huge science and research establishment, and our colleagues here in the industry as well would like to participate with HHS. Are there any bodies, advisory committees, commissions that you've set up where our industry folks from Minnesota can participate as you people are thinking within HHS AI policies?
Yeah, so we don't have, to my knowledge, any AI specific, kind of advisory committee or group at this point. There may be more specialized ones within some of the HHS components that I may just not be aware of them. There is one through FDA, which is called the Digital Health Advisory Committee. If folks are interested in that one, it meets from time to time. That one has had an AI related focus. You could certainly submit public comments to it. My office has a advisory committee as well. It's called the Health IT Advisory Committee. Given that we've just gotten new leadership, we're still kind of ramping up in terms of getting a sense of what their priorities are, whether or not they'd want to have feedback in that area. But if there were, if you haven't signed up for our listserv as a public service announcement, you can go to healthit.gov, and we do distribute on a weekly or periodic basis information to the community about activities.
The community over here, Steve, is very interested in policy determination construct over the next few years, because AI technologies will move with rapid speed. They will, there's won't be a single point where policies are constructed. I think it's going to be a moving target, is what the people are thinking over here. Do you see that evolution happening over several years, or are you expecting some kind of an endpoint where AI policies have been determined by the White House, by HHS, and by the Congress?
If I had a magic 8-ball or a crystal ball to help answer that question, I think my hope, I have to give you personal hope, right? Having been through this a few times with different technological changes, I think there will be areas of public policy where there is kind of a coalescing of ideas, maybe around transparency, like we've started on the health IT side, especially if there is a broader need for health professionals, clinicians, to have certain information available to them in order to be able to compare, different AI technologies. Those types of market dynamics I could see either from a consumer protection or other types of, depending on the lens that you want to look at things. I could see, those normalizing. But it seems like the pace of change is accelerating right now, not decelerating. And I think you feel that sense of urgency, for everyone to try to keep up and make sure that if there are areas where we do see some risk mitigation activities, that may be a place where some public policy could be made as well. I'm not sure that you'll see a top-down, one-size-fits-all, type of approach anytime in the near future.
Maybe then in October we can do a checkpoint and maybe even invite Assistant Secretary Tom Keene to come and join us here in Minnesota in person. And you can come as well. Of course, you'll be invited. Steve, you've been such a great supporter of our work here in Minnesota, and we would love to have you come back in person. Please do pass on my regards to the Assistant Secretary, as well as to the new Deputy Secretary as well. I'm glad Jim O'Neill has been confirmed by the Senate, so it bodes well for the country. Thank you so very much. If there are no other questions, may I get a round of big applause for Mr. Steve Posnack. Thank you, Steve.
All right, take care.